So Tiziana, we talked about the strong positive, the moderate positive. What about the negatives?
You get the easy question.
Do they have a driver mutation?
No, they don't.
All done. I think the PD-L1 negative population is certainly the most challenging population. If you look at Keynote 189, though, I think as a standard treatment option, the PD-L1 negative population did seem to benefit from chemotherapy in combination with pembrolizumab. And certainly if you look at 407 similarly, they also benefited. So I think for the PD-L1 negative population in general, as of now, I think those are patients that do seem to benefit from chemoimmunotherapy, although we realize and recognize that they don't do as well overall. And there are a lot of questions about what is the optimal therapy for the PD-L1 population, and what is the optimal biomarker, and do they have another marker that does suggest that there's a benefit of immunotherapy, talking about TMB and others that are coming along.
And the other area that we should discuss is, there's in my opinion, substantial preclinical data looking at the importance of VEGF as involved in the tumor microenvironment and immunosuppression. And of course we had what I think is probably the most impressive trial lately is Empower 150. I'm just kidding.
Could that be because you were the PI mark?
But that kind of tested the hypothesis of in just so everyone knows the design. The control arm was essentially ECOG 4599, carbopaclitaxel, bevacizumab, and then the two investigational arms were either an add-on strategy, which you take advantage of the anti-PD-L1, anti-VEGF effect, or the substitution strategy. And to make a long story short, it was a positive trial. It met PFS and OS. I guess since it did get incorporated in the NCCN guidelines, it was guideline changing. I don't know if it's practice changing for lots of different reasons we can discuss, but there were a couple of subset analyses that were particularly interested that were pre-planned, and one was in the EGFR ALK space, and the other was in the presence of liver mets, which was based on the observation from ECOG 4599 that there was a substantial benefit due to bevacizumab in the liver met population. So that was a special subgroup here. So I might be interpreted as being biased by discussing more of the results. I just want to get other people's. Let's start with the EGFR stuff, right? Because this is the only trial to date that's included EGFR ALK patients.
It is, well, so Empower 130
I'm sorry,
did, right?
yes.
And so that's an interesting compare and contrast. So for Empower 150, in the EGFR patient population, there definitely was an overall survival benefit that was shown, again, in a subset, albeit planned, but it was still subset analysis. And so I think we have to be a little bit cautious how to interpret that. I have given that regimen to some patients, and I've had at least a couple of them where they do seem to be benefiting from it. And so I think there's something there that needs further exploration. But we also need to talk about the Empower 130, which was the same carboplatin and the same nab-paclitaxel and the same atezolizumab, plus or minus atezolizumab, but without the bevacizumab. And that also allowed for the EGFR patient population. In both cases, it was a small percentage, 10, 20%. But that was completely negative for the EGFR patient population. So the 3-drug didn't cut it. You needed the bevacizumab. And is that just because it was a random chance from one trial, or is it really a biological impact? I mean, I truly believe that there is a VEGF interaction in the setting of EGFR, and we're going to see the Relay trial presented at this, ASCO, and we have their Latin bevacizumab, and lots of preclinical data. So maybe, but I'm still trying to understand it fully.
And my favorite slide at Santa Monica this past year was John Haymack's slide that said, what's the best biomarker for VEGF therapy? It was EGFR mutation.
Right? And John's work has been, he's really been leading a lot of that too.
Yeah, that's right. Corey?
So if you go back and look at your trial, Empower 150, the separation in the PFS curves are actually a bit more pronounced beyond the median. And whether that's just serendipitous or if that is a reflection of potential synergy between checkpoint blockade and angiogenesis inhibition. The chemo's done at that point. It was 8.3 versus 6.9 months. The chemo would be done by 4 to 5 months. So I think that adds further speculation about the potential interaction. And frankly, the hazard ratio is 0.55. It was even lower for those who are in the TKI refractory group, which is where, frankly, I have actually applied this regimen in the real world in clinical practice. I have used the 4-drug combination. Ironically, it's not approved in that population, yet that, at least not
in the
formally
U.S.
approved.
In the U.S. Outside the U.S.
The rest of the world is a little bit more reasonable in this regard, but at least in the U.S. it's not. But based on those data, based on the hazard ratios, and based on the publication, I've managed to get insurers to cover it.